on the topic combined probiotic for women, effectiveness and safety from the point of view of evidence-based medicine. Over the past decade, there has been a notable rise on the prescriptions of probiotic as confirmed by our analysis of scientific literature. According to the GVP market report shown on this slide, the global probiotic market is projected to increase by an additional 14% by 2030. Importantly, the application of probiotic today extends far beyond treating antibiotic-associated diarrhea, irritable bowel syndrome, or intestinal dysbiosis. Evidence from clinical studies supports their use in restoring the vaginal microbiota as part in integrated therapy and for psychocognitive disorders, for optimizing GI function, and as adjuvant treatment during chemotherapy with anti-tumor agents. As highlighted in the study by Difei Yao, visible on the slide, 38% of probiotic prescriptions are issued in surgical department, and while 42% are attributed in internal medicine. A design factor on probiotic therapy has become a fundamentally new approach to dosage of probiotic. The dosage of 2 to 10 million colony-forming units of beneficial bacteria, which was used on probiotic therapy during the first 50 to 7 years of clinical practice, is now considered an effectiveness. They achieve a therapeutic effect and restore the microbiota. It is currently recommended that probiotic formulation contain no less than 10 billion CFUs. A more effective direction in probiotic therapy is the use of combined probiotic formulation. Current preference are given to combination of various lactobacillus strains, particularly in gynecology, as the use of such probiotic combination allow for the restoration of both the intestinal and vaginal microbiomes in women. Another key issue, the availability of a solid evidence base confirming the clinical efficacy and safety of probiotic bacterial use. Today, it has been clinically proven that a healthy vaginal microbiota includes specific strain of lactobacillus, such as Lactobacillus crispatus, Gasseri, Einers, Jansenii, Acidophilus. Those particular lactobacillus strain are recommended for preventing pathogen invasion and for the treatment of vaginal dysbiosis, including candidiasis. The aim of our study was to analyze the clinical efficacy and safety of a combined probiotic product for women from the standpoint of evidence-based medicine. As a model, we selected the probiotic Florium A, which contained lactobacillus capable of restoring both the intestinal and vaginal microbiome. Given that Florium A is a combined probiotic formulation, we decided to conduct exploratory and analytical research of each of its individual components. A total of 257 scientific publications from the databases shown on this slide were reviewed. Inclusion criteria were based on the relevance of each study to the keywords listed. Lactobacillus crispatus is a dominant species with the healthy cervical-vaginal microbiota in women. It produces high amount of lactic acid, exerting a bactericidal effect on pathogenic bacteria such as chlamydia, gardnerella, and others. Studies have shown that Lactobacillus crispatus facilitates trophoblast invasion by enhancing the activation of the matrix metalloproteinases MMP1 and 2. When Lactobacillus crispatus predomination it has in the epithelium, it creates optimal conditions for implantation in early placentation. Lactobacillus crispatus also normalize vaginal IL-1 alpha level, reduces local inflammation, and promotes epithelial integrity. According to numerous researchers, Lactobacillus crispatus is considered a biomarker of vaginal health and has the highest potential for restoring and optimizing the vaginal ecosystem. Additionally, its capacity to normalize intestinal microbiota has also been demonstrated. The next component of Florium A is Lactobacillus gasseri. Unexpected clinical findings regarding Lactobacillus gasseri were presented in the study by Nishida. The authors demonstrated that even short-term use, just 1 week, of Lactobacillus gasseri at a dose of 2 billion CFU of more important clinical symptoms associated with stress and irritable bowel syndrome. Importantly, Lactobacillus gasseri exhibits bacterial activity and significantly reduce the presence of pathogenic bacteria, both intestinal and vaginal, as shown on the slide. The effect is related to its ability to suppress CLDase activity, modulate the expression of TNF alpha and IL-1 beta, decrease myeloperoxidase activity, reduce bacterial adhesion, and inhibits biofilm formation. Numerous randomized clinical trials also confirmed that oral administration of Lactobacillus gasseri helps normalize the vaginal microbiota in women and contributes to reduction of visceral fat in obese adults. A recent double-blind placebo-controlled clinical study by Shavada and colleagues demonstrated that Lactobacillus gasseri positively affects mild menopausal symptoms, increases level of calcitonin and serotonin to A, reduced deoxypyridine in urine, and improves vaginal epithelial health. The next component of Florium A is Lactobacillus jensenii, which, according to numerous studies, play a key role in urinary tract health. Lactobacillus jensenii suppresses the growth on uropathogenic bacteria. A decline in vaginal Lactobacillus jensenii is associated with a significantly higher risk of urogenital infection, including Neisseria gonorrhea. It has been shown that Lactobacillus jensenii produces two protease-sensitive components similar to analase that prevent the adhesion of pathogenic bacteria to epithelial cells. Additionally, the Lactobacillus jensenii strain, as shown on the slide, influences TLFP signaling pathway, reducing inflammatory responses and positively affects the human immune system through cellular and molecular interaction with intestinal epithelial and immune cells. This strain also downregulates the expressions of pro-inflammatory cytokines and chemokines. As an immunobiotic, Lactobacillus jensenii might also be effective in inflammatory bowel disease. The next component of chlorium A is Lactobacillus rhamnosus, also known as LGG. Over the past 2 decades, extensive preclinical researches on LGG has provided profound and unique insight into how this probiotic strain may influence human health at the molecular level. Most notably, LGG has a proven effect of modulating the immune system. LGG effector molecules regulate immune tolerance by interacting with macrophages, lymphocytes, antigen-presenting cells, and intestinal epithelial cells, ultimately increasing the production of secretory IgA. Vaginal dominance of Lactobacillus rhamnosus strain is associated with a lower risk of genital infection. Furthermore, Lactobacillus rhamnosus significantly reduce adhesion of urogenital epithelial cells and disrupts biofilm formed by Candida, Gardnerella, and other pathogens. It has been established that LGG exhibits pronounced antioxidant properties. LGG effectively and progressively reduces the impact of cationic radicals, including malondialdehydes, enhances the activity of glutathione peroxidase and superoxide dismutase, acquiring importance the LGG ability to modulate GABA receptor expression in the brain, producing anxiolytic effect and potentially contributing to the treatment of depression and other stress-related disorders. LGG is also capable of producing beneficial substances such as 5-hydroxytyramine, short-chain fatty acid, brain-derived neurotrophic factor. In addition, LGG can regulate brain activity and enhance neurological function via the vagus nerve, the GLP-1 signaling pathway, and more. The final component of Fluorium A is Lactobacillus acidophilus. In just the past 5 years, the international database PubMed has indexed 129 scientific publications dedicated to the study of Lactobacillus acidophilus. The body of clinical research of Lactobacillus acidophilus confirms its broad pharmacological potential as illustrated on the slide. Another interesting fact related to use the probiotic combination in women is the positive effect on skin health. The skin improving effects of probiotic includes anti-photoaging effect, a skin whitening effect, anti-wrinkle effect, moisturization skin, body odor reduction, and anti-aging effect. An important consideration is the choice of optimal dosage form. The clinical efficacy of oral versus vaginal administration of probiotic continues to be actively discussed. It is necessary to determine whether the use of oral probiotic in women with vaginal dysbiosis is clinical appropriate. A meta-analysis by Cookie et al. Reviewed 23 randomized clinical trials involving more than 2,000 women with diagnosis recurrent vulvovaginal candidiasis. The finding indication that topical probiotic preparation did not show superiority over oral administration in restoring vaginal microbiota balance. Moreover, the use of oral probiotic in women with vulvovaginal dysbiosis also led to normalization of the intestinal microbiome. To summarize the result of our analysis, we can conclude that an effective combined probiotic should meet the following criteria. Combination of lactobacillus, optimal dosage, available of evidence base of each component, and optimal dosage form. A probiotic product that meets of all these criteria is Florium A. Florium A is a complex of clinically proven lactobacillus. It supports the restoration and maintenance of urogenital health by enhancing immunity and normalizing both intestinal and vaginal microbiota. It was an honor to share the result of our research with such a distinguished audience. I hope that the data presented today will contribute to a deep understanding of the role of probiotics in the women's health and open the new perspectives for clinical applications. Thank you for your attention.
Of Health and Sports Science, Department of Physiotherapy. I'm from Poland, from Wrocław. Today I want to talk about possibilities to use therapeutic massage, tensegrity massage, in the case of piriformis muscle syndrome. The first, maybe I will be talk about what is this piriformis syndrome. This is piriformis syndrome. This is problem with tension piriformis muscles. Often this tension is higher, is abnormal. The symptom of piriformis syndrome results from compression and irritation of sciatic nerves by the piriformis muscles. The typical symptom of the condition is pain in the buttock area, which intensive in the sitting position, is often felt in the lumbar region as well, and sometimes reaches to the lower limb. We have and we used many physiotherapy techniques and methods. Many of these techniques have been found to do the effectiveness in management is this problem, like nerve mobilization, stretching muscles, massage, work with fascia relays, deep massage, and therapeutic massage. What is tensegrity massage? This is therapeutic massage, but in tensegrity massage we use rules on principle of tensegrity. What is rules? When we have problem, when we have an increase in tension of one muscles, often causes abnormal tension in the connective tissue structures that are in direct and indirect contact with this one muscles. Here I have photo. We see here one muscles and another muscles. This point, this is bone when a lot of muscles have attachment. When we have problem with one muscles, when we have abnormal tension in one muscles, we have two direction change. We observe the change in this one muscles and we observe reaction in another muscles. Why? Because activities, the forces of pulling and squeezing in each muscles. When we have problem with abnormal muscles, we observe reaction in not only muscles, but we see change with vessels, lymphatic and venous, and arterial and nerves. Why? Because all the structure are in this one muscles. Rules of tensegrity, rules of structure and muscles is because we need structural homeostasis, increase and in the resting tension of the one muscles will include change in tension of the other muscles. Which muscles that are in direct, often indirect contact with this one muscles. Why? It in order to maintain balance, structural homeostasis. Local change in one muscle causes often distal global changes. Change in one muscle can affect change in the vessels and nerves located with it. When we have situation when we have piriformis syndrome. Here is muscles piriformis syndrome. On the top is this muscles. Of the muscles, we see very important artery, superior guttural artery. We see only two big branches this artery. One branches is for muscles, posterior part of this area of hip and pelvic, and the second branches, this artery is for bone, hip bone, posterior part, and when we see anterior part is bone, this artery meet with two muscles, trapezius lumborum and iliopsoas lumborum. And when we have problem with this two muscles, abnormal tension, these muscles may compress the superficial branch of the superior guttural artery. And I come back to the piriformis syndrome. Next connective, next relationships. When we have problem, abnormal tension and piriformis muscles, here under these muscles, at the bottom of these muscles, we see sciatic nerves and we see inferior guttural artery. This artery have a lot of branches, but one branches go to the sciatic nerve, and second branch, this artery go to the very important sacrotuberalis ligaments. When we have problem with piriformis muscles, we have problem in all muscles, not only one muscles, and we have problem with not only muscles and artery and ligaments. When we have abnormal tension piriformis muscles, these muscles pressure and causes often entrapment sciatic nerves. When we have problem with sciatic nerves, we can abnormal tension or symptoms, not only this region of hip and pelvic earth, we can problem with muscles and symptoms tone in lower leg and foot. When we can, in this situation and piriformis syndrome, use tensegrity massage, because in tensegrity massage we have a four system. One system, this is group muscles, which are in contact, direct and indirect, and together work, together functional. When I see localization sciatic nerve, and when I see for system tensegrity massage, I see the same way, I see the same muscles. When I can use these muscles, work these muscles in massage therapy, and work with these muscles can be with attachment for these nerves. When I see tiered system massage in tensegrity massage, I see the same tissues, the same muscles, which is in piriformis situation, piriformis syndrome. When I do tensegrity massage, I use special position, lying of the side position. This position is safe for patient and massage therapist. This position is comfortable for joints and muscles. Position providing relaxation of the maximum number of muscles, ensuring the proper flow of wellness, blood and lymph. Very important in this position is the joints of lower limb are this one higher, this one level. This is good condition for manual work with the muscles in the hip area, in the pelvic girth and lumbar section of the spine. Okay, and next. I was with my patient. I worked with my patient, with women 6 years ago, but topic piriformis syndrome is still a big problem for many patients. She had very attractive she was very attractive person. She was very activity person. She had first very big problem, very big symptoms, pain 18 years ago. Why? Because a long time work in one position in office, and then long time go to the driving car. She spent the whole 1 year looking for the causes the symptoms. She had consultation and many visit in specialists and medical specialists and doctors and specialists from physiotherapy. She had many diagnosis tests. Here we see change in lumbar spine. She had the gross lumbar lordosis and degenerative change in many levels in intervertebral joints. When she goes to the family doctor, this family doctor sent her to me. She had symptoms. Pain in the lumbar spine, pelvic girth, hip, on the lower limb. The pain was decreased while walking. The pain was worse when track was bent forward. The pain aggravated when sitting in chairs for a long time. Pain was in the buttock, back, on the thigh, popliteal fossa, and the calf. Purpose the therapy, the tensegrity massage, very important, was reduction of pain and normalization of resting muscle tone. Before therapy, I used visual angle scale and I used pressure pain thresholds and did palpation evaluation. And then I did tensegrity massage and used questionnaire about symptoms. In tensegrity massage, we have a special card. In this card, we have 4 systems. We have a point, we have bone. When we touch this bone, is placed when muscles have your attention. Attachment. When I touch this bone, I ask patient, what do you feel? Touch, pressure and pain. When patient feels pain, I must work with these muscles. Methodology massage, the massage was performed 8 times, twice a week, each time for 45 minutes. Massage methodology included the development of palpation. This palpation, I work with selected muscles about one system and second system. I work with all muscles about third systems and second systems. And then I use friction techniques, massage friction and stroking and transversal kneading when I work with one muscles. and in the selected muscles, I did friction in the tendinosus part of the selected muscles. After therapy, very important for us, for patient and for me, was change in the pressure pain threshold. Before therapy, this was were very small, and change during therapy, and the best, well, it was after therapy. Low will it decrease a pain symptom in the major tissues. Increased walls show lower sensitivity and higher threshold. Yeah. I used visual analogy scale. Before therapy was 7. This is very intensive pain, very intensive symptoms. She changed during the therapy. After therapy was very, very great. Decrease. Only patient felt only 2 points pain. My conclusion, massage is effective form for therapy for pain caused by abnormal tension of the piriformis muscles, which pressing of the sciatic nerves. Tensegrity massage regulates resting muscle station by eliminating pressure of the nerve along its course. It improves blood supply to the muscles located along the courses of the nerve and blood supply to the nerve itself. After therapy, patient women change in your life, change diet, change in kind physical activity. She start using relaxation position after work. This is very good information. At the moment, we continue the research. At the moment, with my team, with professor, we work in hospital with person who have problem with lower limb, with problem with piriformis syndrome. These people work in office. We do tensegrity massage. Now we measure of tissue pressure sensitivity, and we pressure the temperature of the areal bleeding processing. Medical doctor do vascular ultrasound of the buttock pelvic guard, and we want to see and we want to inform about blood flow in the gluteal areas. Thank you very much for your attention. I apologize for my English, but thank you.
Thank you, Dr. Ivana, for the excellent presentation.
A little bit about myself. I trained as a pediatric nurse, qualified in 2009. I started as staff nurse when I finished in 2009 in the NICU at Frimley. And then I completed my level 7 405 course at St George's University of London Hospital. And I became a sister in 2013. And I did my training to become an advanced neonatal nurse practitioner in Southampton between 2018 and 2020. When I finished that course, I started on the SHA rota, and then I was on the SHA rota for a year, and now I currently work on the registrar rota at Frimley Park Hospital. I completed my dissertation master's programme in 2023, and I published my systematic review, which I'm going to share with you today in 2024. So, working in the neonatal unit, I've obviously seen lots of babies born with respiratory distress syndrome, and I've also performed lots of less invasive surfactant administration. And what I found was babies who are small do not tolerate very well, I found, when you are giving them sedation before you do the less invasive administration, and they often needed intubation. So I wanted just to explore the research and to see if there was any other research out there to support my theory. So background on RDS. So RDS is caused by a deficiency of the pulmonary surfactant production, really common in preterm infants under 34 weeks. It may occur in the term infant if the mother has diabetes, the baby has an infection, meconium aspiration, or hypothermia or low blood sugar. So treatment antenatally with steroids can reduce the risk of RDS, But however, even with antenatal steroids, babies who are born extremely preterm often will have RDS and will need surfactant after delivery, especially babies under 30 weeks gestation. So in the past, what we used to do with babies with RDS, they were intubated, mechanically ventilated, and the surfactant was administered via the ET tube. And the reason we are trying to move away from this is because research shows that medical ventilation in neonates can increase the risk of bronchopulmonary dysplasia, pneumothorax, and even intraventricular hemorrhage. So in the 90s, there was a technique to administer surfactant less invasive called Insure. So the baby would be mildly sedated, given surfactant through the ET tube, and then extubated straight away. So the benefit of this was being minimal time of being mechanically ventilated and reducing the risks that go with being mechanically ventilated. But the issues with Insure is that once you've intubated the neonate, often preterm, it's very difficult sometimes to extubate them. So we were finding when we were extubating them, they would have loss of respiratory drive, and then we would have to re-intubate them and manage them on the ventilator, which is something we were trying to avoid with Insure. So less invasive surfactant administration, we don't intubate. What we do is pass a tiny catheter through the vocal cords to the awake, spontaneously breathing infant, and we deliver that surfactant very, very slowly over 5 minutes. So when we do the LISA or the mist, we have to make sure the baby is breathing sufficiently for the procedure to work. As I say, it takes over 3 to 5 minutes to slowly give the surfactant through this LISA catheter, so the baby does need to be awake. So following LISA, the surfactant spreads quickly, making its use of all of its properties without the need for any positive pressure ventilation. And it is now the most common way of delivering surfactant in the UK. However, the need for sedation is still a debate. So sedation may increase the chance of an uneventful, smooth, successful LISA procedure. However, it may also compromise the infant's respiratory drive, which is necessary for the procedure. So infants that don't receive sedation are less likely to suffer loss of respiratory drive, and they actually, are less likely to need intubation. However, it is a painful procedure. They may resist and may struggle to cry. This can cause an increase in intracranial pressure and could increase the risk of IVH. So it's really, really difficult to weigh up the benefits to sedate or not to sedate, especially when you're looking at the preterm versus term infant. So currently there are no clinical guidelines to state whether to give sedation or not. Many neonatal units give a small dose pre-procedure for analgesia, although this is down to the discretion of the clinician who's performing the procedure. Most term infants will tolerate a small amount of sedation before we give the surfactant, and actually it does seem to help the bigger babies when you give them a tiny amount of sedation before. It does help with the procedure, and they usually tolerate and don't need intubating afterwards. The preterm infant, when they are administered sedation, often become apneic bradycardic during the procedure. Some of them need intubation ventilation, and this obviously defeats the purpose of LISA, which is what we're trying to do. So we need the baby to be breathing, and often the little ones do not tolerate very well with sedation. So the primary aim of the literature review was to analyse the literature and evidence surrounding LISA for the preterm infant with or without sedation, taking into account their gestational age and their weight and other factors. So when I did my search strategies, I used the PICO tool, and I obviously entered all my data. Inclusion and exclusion criteria was applied. The full results of the search were then exported to organise the search results, removing duplicate citations and selecting studies. As the question in this assignment explores medication in comparison without papers will come under the quantitative paradigm, and 8 studies were selected for the literature review. And cast was this is my Prisma. And these were the papers selected. So one was sedation during minimal invasive surfactant therapy in the preterm infants by J. Decker. The second one was propofol for sedation during less invasive surfactant administration in preterm infants by CS Decamps. The third paper was administrating atropine and ketamine before less invasive surfactant administration resulted in low pain scores in a prospective study in premature neonates, and that was by L. Bourgin in 2018. Paper 4 was sedation during minimal invasive surfactant therapy, a randomized controlled trial by J. Decker as well in 2018. Number 5 was quality assessment responsive to less invasive surfactant administration without sedation by D. Court. And the 6th paper was pre-medication practices for the less invasive surfactant administration, results of a nationwide cohort study. And that was by P. Krasecki in 2020. Number 7 was pre-medication with ketamine or propofol before less invasive surfactant, an observational study in the delivery room by C. Brolandi, 2021. And number 8 was pre-medication with fentanyl for less invasive surfactant application, a randomized controlled trial by HC, 2022. So a lot of the papers didn't actually look at the rates of failed LISA. They were more looking at the comfort scores during LISA. So I managed to extract the data to put together the systematic review in the paper that I published. So this critical appraisal for paper 1, so this paper looked at LISA significantly higher in the sedated group. So the sedated group actually tolerated the surfactant versus the non-sedated group. The mean length of duration was higher in the sedated group, 2 to 4 minutes versus 0 to 2 minutes in the non-sedated. 33% of the non-sedated required positive pressure ventilation versus 100% of the sedated infants in the last study. And the samples, so risk for validity and bias, the sample size was very small, and the nurse who was assessing was not blinded. Paper 2. So the appraisal summary, I found that 14% failed LISA attempts, 20% of the 35 infants needed intubation for the second dose of surfactant. The desaturation below 85 was noted in 21 of the infants reported as in 100%. Oh, apologies. Sorry about that. Infants experienced bradycardia. 17% of infants experienced bradycardia, and 14% had a low mean blood pressure during the procedure. So the risk for validity and bias, so the results do not reflect the percentages accurately in this paper due to missing data. It was a small sample size, and no specific statistics were mentioned in the results table. In paper 3, so they did a FAN score, so 56% of the infants who had ketamine showed that they were comfortable during the procedure and tolerated the LISA. 41% of the infants were intubated immediately or in 72 hours post-LISA after having sedation. The rate of desaturation and apnea was high at 52% because of the possibly attributed because of the ketamine. And a RAM cannula was used to deliver positive pressure ventilation during LISA rather than a bag valve mask. The risk for validity and bias, so there was no control group. Individuals who are part of the trial show regret bias when starting the use of positive pressure ventilation rather than their RAM cannula, and it was a small study sample. So the paper 4, so the comfort score during LISA was significantly lower in the sedated group. So obviously that shows that the babies were uncomfortable if they were non-sedated. However, the length of desaturations were very much higher in the sedated group versus the non-sedated group. In both groups, the heart rate was significantly lower after the procedure. However, the sedated group, the difference in heart rate was significantly lower than the non-sedated group. More infants in this group needed positive pressure ventilation if they were sedated rather than the non-sedated. And only 1 infant in the sedated group was intubated compared to 4 infants in the sedated group. There was no significance between IVH and pneumothorax, and risk for validity and bias. The individual was not blinded carrying out the procedure. Paper 5. So This shows that lethal was successfully attempted first time in only 45 of the patients, and 2 attempts were required in 9 of the patients. 34% quality of technical conditions was inadequate, and the vital parameters were only measured in 37 of the infants. And lots of infants desaturations below 80, I think it was 68% in the sedated group rather than 47% in the non-sedated group. Again, risk for validity and bias. The individual carrying out lethal was not blinded. There was no control group and there was data missing. Paper 6. So the pre-medicated infants had the lowest maturity and birth weight. Again, this will just show that this was down to clinical discretion rather than anything randomized. That ketamine was most common used pre-medication in this study. Only 2.3% of the sedated group needed intubation compared to 1% of the non-sedated group. Desaturation rates between groups showed statistical differences, and apnea was more common in the sedated group. Again, risk and validity and bias. The large sample size, and there were confounding variables, which may result from different types of sedation or analgesia used in the study, as there were many rather than just one. Paper 7, so intubation rates were not significantly different between the groups. Mechanical ventilation was required in 42% of the patients in the ketamine group versus 34% of the propofol group. The incidence of positive pressure ventilation, IVH, neck RP were all statistically very similar. The risk of validity and bias, the individual carrying out was not blinded, and there were no parameters measured during the LISA. And on the last paper, the percentage of the infants who were showing discomfort was significantly higher in the placebo group rather than the fentanyl group. Vital signs showed no statistical differences between groups. Only 1 infant in the fentanyl group was intubated during LISA, while none of the non-fentanyl group needed intubation. The rate of intubation the first 72 hours was similar in the 2 groups, and no differences were observed in PDA, IVH, or the risk of NEC. So ethics. So both the randomized controlled trial papers specified that consent for enrolment was obtained by a parent or guardian. The prospective and retrospective cohort studies did not require formal consent from a parent or guardian, although they had consulted and gained consent from the local ethics approval committee to obtain and analyze patient data retrospectively. The remaining prospective studies did not mention ethical approval or consider in their paper. They didn't mention it at all. So the number of infants included in the studies ranged from 29 to 495. Only 2 studies used a population of over 100, and all were receiving some form of non-invasive respiratory support with an oxygen requirement as part of their inclusion criteria. 3 studies used ketamine as their sedation drug, 2 used propofol, 1 used fentanyl. The large multi-center study used a combination of medications, including ketamine, propofol, fentanyl, midazolam, phenobarbital, and sulfonyl, depending on what the unit's protocol was. The volume of sedation administered also varied with the dosage depending on the level of activity. 4 studies compared use of sedation with a controlled group that did not receive sedation, and 3 of the studies did not have a control group observing LISA under sedation only. The remaining LISA study observed LISA under no sedation. So after examining all the literature, there is no evidence to support actually either way whether to give or withhold sedation in the preterm neonate who's requiring LISA. So additional studies are needed to be looked at this question, ensuring more randomized control trials with a wider sample selection size and adequate blinding would help future practice. Thank you. Is there any questions?
So, good morning, afternoon, or evening. My name is Dr. Duha Abdullah, and I will be presenting the findings of an audit titled The Impact of Ordering MRI Before Histopathology Report on Timely Medical Management. was CA 125 constantly high in material cancer diseases or cases? Were patients informed of potential diagnosis wearing hysteroscopy? The study was a descriptive cross-sectional audit based on patient files from these three hospitals. We included 8 patients with postmenopausal bleeding and complete data records. This graph shows the hospital distribution of the cases, with the majority being from Gynecology and Prince Philip hospitals. This figure shows the type of presentation, and we found that a percentage of the cases were discovered incidentally. And here we can see when hysteroscopy was performed. In the 62.5% of cases, it was done at the first outpatient appointment. In the remaining 37.5%, it was delayed. The hysteroscopy reports were suspicious in 75% of cases, and only one case had a benign result, as seen in this table. In this chart, you can see the timing of MRI scans in relation to histopathology reports. And as you can see, in 57.1 of cases, MRI was performed before receiving the histopathology report. And here, MRI findings show that most patients were diagnosed with stage A1A cancer, with 1B stage, which is crucial for treatment decisions. So here, this graph shows that most patients underwent surgery, while only one received conservative treatment, as this figure here illustrates. And again, 62.5 of patients were informed about a suspected diagnosis during the hysteroscopy appointment, which emphasizes the importance of patient communication, of course. CA 125 levels were generally low, with only one patient having a high value. The median was 16, as shown here. And this slide shows the median time gaps in the diagnostic and treatment process. The most significant delay was between hysteroscopy and the first definitive treatment at 87 days. Well, statistically, there was no significant difference in treatment timelines between patients who had MRI before versus after. However, 75% of early MRI patients were eventually diagnosed with cancer, compared to 66.7% in the other group. And based on the findings, we recommend updating policies to delay MRI until histopathology results are available, unless urgent imaging is needed. Patient communication and ongoing education and regular audits are key parts of our proposed action plan. Thank you so much. This was my discuss the implications and literature review. Umbilical cord aneurysm is an exceptionally rare vascular condition. It often escapes prenatal detection and poses life-threatening risks to the fetus. So it's life-threatening to it. The clinical presentation varies, and the condition is often missed unless complications arise. Although the exact cause is often unknown, structural anomalies in the vessel walls or turbulent hemodynamics are suspected. Associations with chromosomal abnormalities make genetic testing a critical consideration. These aneurysms may remain silent until catastrophic rupture occurs. Cesarean section is often recommended to avoid mechanical stress or on the compromised vessel during vaginal delivery. Our patient had an unremarkable antenatal course. Despite no prenatal diagnosis, the postnatal findings confirmed the presence of an umbilical artery aneurysm, highlighting how much anomalies can escape detection. Despite the critical finding, the neonate responded well post-delivery. The low arterial pH indicated some level of fetal stress, but timely neonatal care prevented further implications or complications. Sorry. Histological analysis confirmed the diagnosis, showing that even structurally normal cords can harbor dangerous aneurysmal changes. The findings highlight the role of clot-induced expansion rather than vessel degeneration. And the rarity of reported cases underscores the need for clinical awareness. Our case contributes to this limited but growing pool of data, which may eventually shape future management strategies. Any aneurysmic lesion in the cord could raise suspicion. Doppler is vital for differentiating vascular from non-vascular lesions, and genetic analysis is essential in cases with other anomalies. A coordinated approach involving frequent monitoring and carefully timed delivery can significantly improve outcomes in these rare cases with better imaging and vigilance. More cases can be identified prenatally. So this case adds to the limited literature and enforces or reinforces the importance of careful umbilical cord assessment during routine ultrasound. Even when the outcome is good, the risk of fetal demise is significant. And this is a list of references for those interested. And thank you very much.
Thank you, Dr. Doha, for the excellent presentations. So, any question?
Good day. I am pleased to talk a little today about the article entitled Endocrine Disruptors with Estrogenic Activity Analyzed in Sanitary Towels, made by Dr. Nicole Fontecha, Dr. Patricia Cifuentes, and who speaks to you, Dr. Corina Pava, of the Colegio Mayor de Cundinamarca University in Bogota, Colombia. First of all, thanks for this great opportunity, and I hope it is of your interest.
We will talk about a relevant topic that most women are concerned with: sanitary towels. These are products we use monthly to manage menstrual bleeding, but unfortunately, they contain chemicals that can have detrimental effects on reproductive and hormonal health, and in the long run, even for pregnancy. The purpose of this exhibition is to show that these products may contain compounds that can cause endocrine disruption, which alter the body's hormonal balance, and their effects can be severe over time. In addition, disposable products such as sanitary towels have a significant environmental impact, generating large amounts of solid waste. Endocrine disruptors are external substances that alter the body's hormonal balance, whether by their similarity of affinity to hormones there's a physiological interference or their impact on hormone receptors, which might have adverse effects on the health of individuals or their offsprings. Some of these compounds can affect the body with effect on fertility, sexual function, sperm production, and cause feminism in men. Each month, the female body is prepared for a possible pregnancy. If fertilization does not occur, vaginal bleeding occurs that removes endometrial tissue from the uterus, a process that usually lasts between 3 and 5 days, depending on the case. This is why alternatives are required to manage this bleeding. For years, women have resorted to products such as sanitary towels, which are used during menstruation, postpartum, or when it necessary to absorb vaginal fluids. These disposable products contain super absorbent elements that, when in constant contact with the body, are associated with risks of endocrine disruption, such as changes to the cervix and reproductive disorders in both women and fetuses. On average, a woman uses about 11 sanitary towels during her menstrual cycle, generating approximately 832 grams of solid waste per year and 8,320 grams over 10 years, the same period as menstrual cup. In comparison, a menstrual cup only generates about 100 grams of solid waste during the same time. In addition, the use of these disposable products has a great environmental and economic impact, which has been pointed at by various studies on the personal care industry. The use of chemicals in the manufacture of these products has also generated global concerns because of its effects on both human health and the environment. This underlines the need to disseminate information on the subject in order to change people's habitats and choice. With regard to sanitary towels, for years or so since the 18th century, women have been looking for different devices, materials, and substances to control their menstrual period. Sanitary towels, which are absorbents, were introduced in the 1895 and remain disposable products to this day. Over time, there has been a great variety and innovation in terms of compositions, presentations, and brands, which has allowed greater economic accessibility and reach to the population, always with the aim of satisfying a need. Sanitary towels are made of layers of fabric such as cotton, mesh, or a mixture of both, and contain absorbent materials such as cellulose or a combination of cellulose with superabsorbent polymer gel. These components have not received sufficient attention for companies, resulting in health problems. Investigations have revealed the presence of substances of concern in their components, for example, bisphenol A, known to be found in plastics products such as packaging and coatings, is also present in phenol absorbents. DeVito and Schechter showed that this compound can alter the chromosome composition, which has raised alarms about its presence in any product. In addition, dioxins have been found in these products, which has raised concerns as they are easily absorbed by the body. What is an endocrine disrupting compound and which ones can be found in sanitary towels? EDC, endocrine disrupting compounds, are external substances that have the ability to alter the immune system response at various scales. These substances are associated with various alterations in the endocrine system of people who have been exposed to them, whether by ingestion, inhalation, absorption, or dermal contact. EDCs are lipophilic, which means that they accumulate in the body's adipose tissue and can remain there for a long time. Assessing the full impact of exposure to EDCs is complex, as adverse effects may take a long time to develop and manifest in later life stage. According to the National Agency for Food Safety, Environmental and Occupational Health, ENES, these disruptors are found in everyday products such as sanitary towels. The agency has identified several of these compounds, including glyphosate, a probable carcinogen, phthalates related to fertility problems, polycyclic aromatic hydrocarbons, which are potentially carcinogenic and harmful to the immune system. Perfume additives, which can be irritant and come from raw materials and manufacturing process. Aluminum, considered a suspect endocrine disruptor. Alcohols, which are irritants and desiccants. Sodium polyacrylate crystals, used in the absorbent core of sanitary towels, known to be irritant and allergenic, although currently banned in tampons, not towels. Hexachlorobenzene, a suspect endocrine disruptor. Butylphenylmethylpropione, a synthetic fragrance, potentially allergenic and endocrine disruptor. Lindsane and Quintosane, pesticides banned in Europe since 2000. Dioxin and furans, which occur in small quantities due to the chlorinated products used to bleach the product. Cotton, one of the common materials in sanitary towels, is exposed to pesticides such as glyphosate during its production, substances that have estrogenic activity. In addition, the towels undergo bleaching process with chlorine and derivatives. Although the organic versions promise less exposure to chemicals, they are not completely free of these products in their manufacture. Another compound present is butylphenylmethylpropional, used to give the product fragrance, but it is toxic and has estrogenic activity. In the absorbent core of the towel, compounds that have been bleached with dioxins or furans can also be found, substances that are rapidly absorbed through the vaginal mucosa. Since this is a fairly irrigated region and easily absorbs the compounds to which it is exposed and can be distributed quickly into the bloodstream. Now let's focus on the health effects. Endocrine disruptors have gained prominence due to the negative health effects that have been identified in recent years, while revealing gaps in studies on this substance. Also, the lack of research in this area is publicly known. The impact on women's health is particularly noticeable. Women are mainly affected by the estrogenic activity of various products, as their exposure to them is greater through cosmetics, pharmaceuticals, health and care and plastics, in addition to their higher percentage of body fat, which facilitates the absorption and adhesion of the substance. It is estimated that between 62% and 75% of women use sanitary towels. On the other hand, parabens present in everyday products such as medicines, food, and personal care products such as sanitary towels are linked to problems such as ovarian aging, breast tumors, and even breast cancer. Dioxins found in some products can cause reproductive problems, affect the immune systems, and are associated with cancer development. The protective function of the vagina, which is made up of multiple layers of dead or decaying cells, is often underestimated. Due to its moisture and irrigation, the absorption of chemicals such as pesticides, dyes and dioxins is facilitated, which can alter the body, even vaginal pH. If the vaginal pH is out of the normal range of 4.5, you may be at increased risk for health problems such as cancer, neurological disorders, hormonal imbalance, and risk of genetic alterations. If the industries producing sanitary towels do not pay attention to the materials used, exposure to harmful agents could increase. In 2013, Women's Voices for the Earth published a report detailing how women's products companies sell toxic products and the health consequences of the substance. Exposure to substances such as phthalates, which are found in many women's care products, has been linked to problems during pregnancy, such as increased risk of loss. In addition, phthalates are associated with endocrine disorders, hair problems, reproductive disorders, diabetes, some cancers, birth defects, brain damage, asthma, and disability. Endocrine disruptors are also associated with obesity, neurological disease, premature onset of puberty, and congenital malformations. Phthalates are present in the coatings of single-use female absorbents, which are used by 75% of the female population. Research shows that the use of menstrual products is currently so common that women have a variety of options, but these products are not sufficiently regulated due to the lack of regulations and standards controlling the quality, quantity, and waste. This has generated misinformation as many women continue to use the products that have traditionally been recommended for them without questioning their safety. The manufacture of intermediate products is subject to regulation that permit the use of estrogenic activity substance at concentration considered non-hazardous. However, many studies examine these substances in isolation with considering their interaction with other components or bioaccumulation process, which could lead to problems. In addition, the effects of vaginal absorption are not taken into account, leaving acid possible a specific risk. Compounds such as parabens, which are endocrine disruptors, are considered safe on their own but need further investigation when combined with other similar compounds, such as in the case of sanitary towels. The most common parabens, methylparaben, ethylparaben, and butylparaben, accumulated in breast tissue and may stimulate the proliferation of cells associated with breast cancer. Other compounds such as DMDM, indantine, dioxins, phthalates, and furans are classified as carcinogens and may cause alteration to the liver, nervous systems, endocrine system, reproductive system, and other conditions. Exposure time and the amount of these compounds absorbed through the use of sanitary towels contribute to these health problems. Since these endocrine disruptors are present in many intimate use products, their contact with vaginal flows is associated with various pathologies, which generates concern among women. However, efforts by manufacturers to develop both safer products, together with demands from health professionals, could lead to the elimination of substances such as DEHP, bis-2-ethyl phthalate, and bisphenol. A 2022 project investigating the use of biodegradable sanitary towels made from banana fiber demonstrates that natural products can be a viable and beneficial option for both health and the environment. With the growing interest in alternatives such as menstrual cups, reusable towels, and washable pants, an opportunity is opening up to improve women's health, reducing environmental and economic impact, and promote change for general well-being. In conclusion, the frequent use of sanitary towels and the presence of endocrine disruptors in these products show an impact on women's health linked to diseases associated with these compounds while contributing to environmental damage generated by waste. Industry's lack of interest in addressing the toxicity of its products is an urgent problem which must be addressed before the consequences for both health and the environment become irreversible. It is essential to promote innovative technologies that better meet the needs of women while contributing to global environmental commitments. Thank you for your attention.
Today, I will be discussing a topic that remains under-recognized but significantly impacts the quality of life in patients: vulvodynia associated with vulvar hypertrophy in adolescents. My presentation will explore its clinical features, potential causes, approaches to management, and a case report with the goal of raising awareness and promoting early compassionate care. Vulval pain can be a chronic and debilitating condition, decreasing the quality of life, requiring careful management and support. So what is vulvodynia? Vulvodynia is a chronic pain condition that affects the vulva, the external female genital area, without an identifiable cause. The pain is usually described as burning, itching, or irritation, and it lasts for at least 3 months. It can be a constant or occur only during activities such as sitting, exercising, or sexual intercourse. Importantly, vulvodynia is not caused by any infection, skin disease, or other identifiable medical condition. It can significantly impact on a physical, emotional, and psychological well-being, especially in adolescents, where it may be underdiagnosed or misunderstood. So like I said, this chronic condition has an impact in the quality of life. They are felt in several areas, such as chronic pain. In its constant discomfort affects daily activities, sitting, walking, exercising, and this may lead to fatigue and sleep issues. Relationship and intimacy issues, pain during intercourse, and can cause fear, avoidance, emotional distance, emotional and psychological impact, such as anxiety, depression, frustration, feeling dismissed or misunderstood. Long-term treatment management, being a multidisciplinary approach, needed often requires time and ongoing support. Self-esteem, shame, embarrassment, and body image concern, especially critical in adolescents. Social and work-life disruption, avoidance of social, academic, or professional activities, limitation in clothing, sports, and public settings. Although there are not epidemiological studies in its prevalence, it is estimated to affect 8 to 10% of women of all the ages. The International Society for the Study of Vulvodynia disease has defined vulvodynia as vulvar discomfort, most often described as burning pain occurring in the absence of relevant visible findings or a specific clinical identifiable neurologic disorder, and has subdivided vulvodynia based on pain, location, and temporal characteristics of the pain. There are 4 classifications. Primary generalized vulvar pain syndrome. It's a diffuse vulvar pain that cannot be precisely localized, often involving the entire vulva rather than just the vestibule. Primary localized vulvar pain syndrome that involves pain that can be precisely pinpointed on the vulva, typically triggered by touch, pressure, or friction. Primary vestibular pain syndrome, characterized by pain that is felt in the vestibular area or can be precisely identified through point pressure mapping. And primary clitoral pain syndrome, defined by pain that is distinctly felt in the clitoral area or can be accurately localized there using point pressure mapping. The etiology of vulvodynia remains unknown, although several pathophysiological theories have been proposed. It is believed to be a multifactorial condition rather than the result of a single cause. Contributing factors may include embryological abnormalities, increased urinary excretion of oxalates, hormonal influence, infection agents, contact dermatitis, neurological changes, genetic and immunological factors, and pelvic floor muscles dysfunction. One potential cause of this condition is vulvar hypertrophy, an anatomical variation of the female genitalia characterized by a disproportionate enlargement of the labia minora. Vulvar hypertrophy can lead to mechanical irritation and chronic friction, especially during physical activities, sitting for long periods, wearing tight clothing, and this constant irritation may contribute to the development of worsening the vulvodynia, especially provoked vulvodynia. I would like to present a case of a 16-year female with no significant medical history who has consulted due vulvar pain that worsened with walking and sitting and a perception of enlargement of labia minora. At age 9, she was detected with right labia minora hypertrophy, treated with labiaplasty. 2 months prior to the current consultation, the patient began to experience renewed growth of the left labia minora, which was accompanied by significant pain. According to the visual analog scale, the pain was rated 9 of 10, indicating very severe discomfort, mainly triggered by walking and sitting. This physical discomfort was also associated with emotional irritability, highlighting the psychological impact of the condition of the adolescent patient. After physical examinations, a gynecology examination revealed hypertrophy of the left labia minora, measuring approximately 2 by 2 centimeters, associated with mild clitoral hypertrophy. Neurological examination identified trigger points that are assigned right here. The patient was scheduled for a left labiaplasty using the trimming technique. Approximately 2 months after the surgical procedure, both the vulvodynia and the emotional irritability had resolved. The pain level decreased from 9 to 1 of the pain scale, with only mild discomfort reported using sanitary pads. Patients with vulvodynia often report vulvar pain. In adolescents with vulvar hypertrophy, the mechanical irritation caused by a large labia can trigger or worsen vulvodynia symptoms. This condition is frequently underdiagnosed, leading to unnecessary or inappropriate treatments such as biopsy, HPV testing, or topical agents that may worsen discomfort. Because vulvodynia has multiple causes and variable response to treatment, a personalized multidisciplinary is essential, especially in adolescents where the physical and emotional impact is often greater. So how we're going to make this diagnosis? A sample of vaginal secretion is collected to assess for elevated white blood cells and abnormal pH levels. Cultures may also be taken to test infection. If it's necessary, we can perform a tissue biopsy to rule out neoplasms or underlying causes. If the patient can tolerate, we can do an internal exam. A cotton swab is used to assess pain response to pressure, aiding to identification of allodynia to ensure a true and systematic examination. It is advisable to use a structured approach, such as referencing clock face positions. Pain may be rated according to its severity, mild, moderate, or severe. A speculum examination is ideally with a pediatric-sized speculum should be conducted to evaluate redness, erosion, or vaginal dryness. Like I said, treatment must be individualized and multidisciplinary, considering both physical symptoms and emotional and development stage of the patients. Psychological support like cognitive behavioral therapy can be beneficial. Lifestyle modifications, avoiding tight clothing, prolonged sittings, and irritants, recommending cotton underwear and gently hygiene. Drug therapy like topical anesthetics like lidocaine, oral medication in selected cases such as tricyclic antidepressants. Surgical management only is considered in severe or persistent hypertrophy causing pain and distress. So for a conclusion, vulvodynia is defined as a chronic vulvar pain lasting at least 3 months without an identifiable cause. Congenital vulvar hypertrophy is a significant cause, especially in adolescents, leading to pain, emotional distress, and functional limitations. In addition to a local examination, a comprehensive musculoskeletal and neurological assessment should be regarded as an essential component of the evaluation and should be performed. Surgery, such as labiaplasty, offers the most benefit when symptoms are severe, particularly when combined with physiological and pelvic floor therapy. Understanding the link between vulvar hypertrophy and vulvodynia is essential for improving diagnosis, guiding treatment, and ultimately enhancing patients' quality of life. Thank you for your attention. For any further questions or suggestions, I give you my email. And this is a photo of my hospital where I'm currently doing my residency. Thank you.